Okay, welcome to the IMANI REVEALS show. This is where we speak, we are real so that we can live. I'm happy that God has given us the opportunity to meet once again this Monday. Shall we pray before we proceed? Father, we thank you. You've given us another Monday. You've watched over us throughout the week. You've been our provider, our strength, our everything. We commit this discussion into your hands. We know that our health is important to you because our bodies are your temple. We pray, Lord, that you enlighten us, teach us how to take care of your temple as we talk about this topic, sickle cell. Grant us insight, grant us revelations that will guide us as to how to effectively manage this medical issue. We thank you for our guests, Vicky and Enam. Speak through them. Thank you in Jesus' name. Amen.
Amen.
Okay. So once again, we are here. This is where we speak. We are real so that we can live. And today, I'm delighted to have my friends, Vicky and Enam. So Vicky is the Executive Director for the Ghana Foundation for Sickle Gene Action. And Dr. Enam Bankas is, how do I say it? A doctor, yes, at the Department of Haematology, Korle-Bu Teaching Hospital. And today we are talking about sickle cell. I'm sure if not all of us, most of us have heard about it, and we might know one person or another who is affected by it. So let's join the conversation and get educated so that we can live the abundant life that Christ has given us. Before we proceed, I want to remind us, if we haven't subscribed, go to the IMANI REVEALS show on YouTube, subscribe, and also share the link with others so they also benefit from our discussions. So, who do I start with? I'll use alphabetical order. I'll start with Enam. Tell us, what is sickle cell?
Okay, so to make it simple, sickle cell disease is a genetic disorder, which means that it's inherited and it occurs as a result of a defect in hemoglobin. Hemoglobin is simply a molecule in our red cells that carries oxygen around the body. So there's a mutation or a change in the structure of the hemoglobin that changes it from its normal structure to an abnormal form. And when this happens, then the normal variant of hemoglobin that is called A becomes an abnormal form. And we say that someone has sickle cell disease when they have the S form of the abnormal hemoglobin and any other abnormal form. So to put everything together, sickle cell disease is a inherited hemoglobin disorder that occurs when somebody has hemoglobin S and any other abnormal hemoglobin. So that's just a summary of it.
Okay. So tell us a bit about the work you've been doing around that.
Okay. So I generally say that I have more than 30 years experience with sickle cell disease, and that's
Okay.
because I myself have sickle cell disease and I've been living with this for over 30 years. So that's my first
Contact.
avenue through which I know about sickle cell disease and by which I deal with it. But then apart from that, I've been an advocate for sickle cell disease through the health advocacy group I founded in 2013 called Sickle Life. And so this is another way by which I work in the sickle cell space. And here we raise awareness about sickle cell disease. We provide support group platforms for persons living with the condition. We do welfare activities. provide mentorship and things like that. So this is another thing that I do with sickle cell disease. And then, of course, I'm a medical doctor with an interest in sickle cell disease. So currently, I work at the Department of Haematology at the Korle-Bu Teaching Hospital. I've been working there for 5 years. But then prior to that, I also worked at the Ridge Hospital at the Bone Marrow Transplant Center for close to a year. And then before that, I was doing my housemanship then in medical school. So I've been doing that for 9 years. And then for the past 3 to 4 years, I've also been doing some sickle cell disease related research through my work in Korle-Bu and the advocacy group. So in the past 3, 4 years, we've done some research about um, the how people with sickle cell disease (SC) respond to medications such as hydroxyurea, how people with sickle cell disease respond to medications such as crizanlizumab, and also on the social side of sickle cell disease, I've been looking at the impact of health advocacy groups such as Sickle Life on the knowledge and health seeking behavior of people living with sickle cell disease. And then I've also done research on the looking at the data we've collected from our screening activities as a health advocacy group. So in summary, I think that I look at sickle cell disease from different dimensions as a person living with the condition myself, as an advocate for people living with the condition, as a healthcare provider, and then as a researcher into the condition. So this is, in summary, how I manage in the sickle cell disease space
Okay.
currently.
Great. That's a lot. We'll come back to you so that you tell us a bit more about your findings. Vicky, unfortunately, sorry, due to some technical issues, Vicky is unable to activate her video, but her picture is there, so I hope you can connect the face with the name. Sorry, with the voice. Yeah, so Vicky, if you can hear us,
Yes, I can.
can you tell us a bit about your work in the area of sickle cell?
Okay, so Abby, before I get into it, hi, and Abby, one thing you should know is that a lot of people in the sickle cell space go call me Awo Twumasi. So it's
Okay,
quite so when you say Vicky, it throws a few people off because Awo Twumasi is sort of my my
your
my
stage
work name
name,
in
so to speak.
exactly the sickle cell space.
Okay,
Um,
I'll try and
and
say Awoshimizi. I'm so used to the Vicky.
Yeah, so that with that being said, it's nice to connect with you. And she and I have interacted and engaged on a few platforms related to sickle cell disease and in the
Yeah.
space. So I'm quite familiar with her, and she and her body of work, which is just amazing. So for me, being a caregiver and a parent who has a child with sickle cell disease, my journey with everything sickle cell started 16 years ago when my child was born with it, and I had to quickly learn about sickle cell disease. But also, what I realized I needed to do was to, in addition to educating myself, was to also serve in a role of advocacy for people with sickle cell disease, particularly in the African community, because my child was born in the US. And so, the resources there are quite different from in Ghana or anywhere else in sub-Saharan Africa, where, our resources are quite limited. And even within the Ghanaian communities abroad, in the US particularly, there's still lack of information, awareness, stigmatization in that space. So I quickly found a need to, join the advocacy train. And then if I wanted to see a change, I had to be part of the change, which is to
Yeah.
advocate for it. So that's how my journey started. And then fast forward to when my family and I relocated to Ghana 5 years ago. Again, I had to throw myself into sickle cell because I needed to know what resources were available to my child, but also, the extent to which the resources we were familiar with in the US were available in Ghana, and what we needed to do to bring ourselves up to speed. So I quickly got into advocacy. I worked in partnership with a few key people in the sickle cell space. The late Professor Frimpong is one of them. He was the former president of the Sickle Cell Foundation of
Yeah.
Ghana. And then also Dr. Brew at Ridge Hospital, who has been such a a great resource and support. And with Dr. Brew's partnership, we started the Sickle Cell Association of Greater Accra Regional Hospital, which is Ridge Hospital. And so over there, I currently serve as the president of the Greater Accra Regional Hospital Sickle Cell Association, and have been running this for almost 3 years now.
Okay.
I've also worked in a few spaces, so on several sickle cell committees in various respects. With Novartis, with Chai, also with the Sickle Cell Foundation of Ghana. And I've been doing this voluntarily, again, because I find a need for us to increase our advocacy base within the country if we wanted to see a change. So, out of that experience, I realized that there's still a huge gap when it comes to sickle cell advocacy nationwide. A lot
Yeah.
of the resources are centered in Greater Accra, but then when you move outside of Accra, there's so many remote areas where they don't necessarily have all the resources they need. So I found a need to establish a foundation that can look at, the sort of the holistic, take a holistic view of the whole country, identify, where resources are needed and how to channel those resources. But more importantly, help us develop a stronger voice as a nation, because we need that if we want legislators to change, if we want resources to come and help us move this fight forward, we need to have a stronger voice in the sickle cell space. And that means we need to collaborate with all of the various groups out there, providers, help, caregivers alike. We all need to come together to make this possible. So that is really what the foundation I established is poised to do in the coming years. So that
That
is my journey with sickle cell thus far.
that's really good to know, and it's really conscientious of you to think of the rest of Ghana. Like you said, most of the time things are centered in Accra, but there are other people outside of the capital who are also experiencing various forms of medical issues, including sickle cell. So
Correct.
kudos and God bless you for that.
Thank you.
So, like I said to Enam earlier, I would like to know your findings throughout the years, the work you've done. What are some of the things that have come up? One thing that should I say fascinates, or which I wonder about why, is the fact that sickle cell disease affects only Africans, if I'm right. Is that accurate?
And that's me.
Any of you?
Um, so yes, there's the perception that sickle cell disease affects only Africans. However, the statistics show that it's quite common in people of African descent, and yes, Africans, especially in the sub-Saharan African region, but also in the Mediterranean region. So you have some um, Indians who have sickle cell disease. You have people, some Italians. You have
Oh.
people in Bahrain who also have sickle cell disease. So it's not just Africans or blacks who have sickle cell disease. However, yes, a large proportion of the people who have sickle cell disease are in the sub-Saharan African region, especially Nigeria, Sudan. That's where the majority of patients or persons living with sickle cell disease are. But to answer your question in general, yes, as Awo said, um, we have the sickle cell disease space in Ghana is quite small, so we've intersected in a number of programs. We've worked on advisory boards for Novartis, sickle cell disease patients advocacy summits, and the likes. And some of the things that keep coming up are, for example, a lot of misinformation or lack of awareness about sickle cell disease. So the people have heard about sickle cell disease. There's a general knowledge about a condition called sickle cell disease, but when it comes to the fine details about it, we find that not so many people are aware of what exactly it means to have sickle cell disease. So they may just know a part of it. So about a classmate who, for example, was always having acute pain episodes, or of somebody who was young and died, but then they don't know about the details of the fact that it's a genetic condition that is inherited, that is because of a mutation in red cells. They don't know the fine details. And so even though they may know somebody who was always in pain or who may have died young, it doesn't connect with the fact that it's a genetic condition and may be preventable. Another thing that we also see is that a lot of the awareness is by people who are directly affected by it. So
Yeah.
you have people like me who has the condition myself, or Awo whose child has the condition, and so it ends up being people who are directly affected rather than the general populace. And so once you go out and you are talking to people, it sounds like a distant possibility rather than, for example, if you were educating someone about HIV, it's something that seems tangible. I could go out there and contract HIV myself. But then if you are telling a young person about the possibility of having a child with sickle cell disease in future, they probably don't even have a partner or a boyfriend at that time. And even if they were to have a partner, the thought of going to get tested and the partner probably having um, the genotype that we are talking about and the possibility of that child having sickle cell, it sounds so distant. So we end up finding that for many people that we might have interacted with, it only becomes real to them when they are close to getting married. And it's
Yeah.
like, but we've been talking to you all this time. So it's the whole time we were talking to them, it wasn't real until it was at the point where now I could have a child with sickle cell. So that's one of the challenges that we've been observing. Another thing that we also see happening is that this happened to me in 2013, 2016, and I think the same thing is happening to Awo now. That's 2023, 2024. That there are so many organizations in the sickle cell disease space because there is a very large gap that needs to be filled. And so we all come in and we see the gap, and then we try in one way or the other to do some work with existing organizations. So when I came in 2013, I tried to work with the Sickle Cell Association, and Awo has been working with the Sickle Cell Association at Ridge. But then at a point, you realize that there's still a lot more that needs to be done, and you feel like you can do that at that thing with another entity when you are on your own. And so we end up seeing a lot of organizations coming up where we all want to try to do something else. And that just speaks to the gap that still exists, because although we've all been around, Awa has been doing this for over 15 years. I've been doing this for the advocacy part for 10 years. There's still this gap and pressing need that even though we've been doing this for so long, every year we are still seeing more problems. And so we still need to come up with new solutions. And so these are the things that are happening in the advocacy space. And that thing that for me is very worrying is the level of stigmatization that keeps coming back to us, the
That's
reports of
surprising.
stigmatization.
I'm wondering
Sorry?
why you should be stigmatized.
It's multifactorial. It comes from a place of ignorance about the condition. It comes from a place of um, making wrong assumptions about the people living with the condition. And the stigma comes in different forms. And sometimes, even when the stigma is happening, people don't recognize that what they are doing may be a form of stigma. And so it's unfortunate that we keep getting these reports of stigma from members of our support groups or from our patients. And it's usually the social stigma or stigma in the school or workplace that we keep hearing of. And for me, it's really challenging, especially because right now the healthcare is improving in terms of the availability of medication is somewhat better than before. So
Okay.
quality of life is improving, life expectancy is increasing. So we are expecting more people living with sickle cell disease to live longer. So we expect them to grow to become contributing members of society. But then if we are stigmatizing in sometimes it's very subtle ways. It could be a family deciding that there's a myth that a child living with sickle cell disease will not live past 18. So based on that information, they choose not to send them to a good school because why waste money? The child will die either ways. Or deciding that the child will not amount to anything. So there's no point investing so much in said child. And then it carries on into the workplace in terms of not employing people with sickle cell disease because you think they'll always be sick and so they cannot perform in the workplace. And meanwhile, you have these people growing on into adulthood. And so once we keep seeing these things, it becomes very challenging because you keep hearing these reports and you keep wondering how exactly or what else can we do, because we keep talking, we keep sending out the messages, we keep showing examples of people living with sickle cell disease who are excelling despite the challenges of the condition. So then the question is, what more can be done? And sometimes the stigma is even within the healthcare system. So sometimes patients go in and they are accused of being drug seekers, right? And it's just because of misunderstanding of the management of pain in sickle cell disease. And so it makes it challenging because then now people don't want to go to the hospital again when they are in pain. And then they manage the pain at home and they end up with complications. And these are all things that make it difficult in managing or interacting with people with sickle cell disease. But I'll hand over to Awo to mention a few more.
Okay. Oh, please go ahead.
So I think for me, just putting things in perspective, because I can freely speak by saying that I'm not a health professional, and but then I've done health education, and I've also learned through advocacy. But what I like to tell people in layman's terms is that sickle cell is a silent illness that may or may not, exhibit on a person physically, but the damage done internally is quite extensive and severe. And so, in layman's terms, how I put it is that sickle cell can affect your brain, strokes. It affects obviously your blood, and the blood runs through every part of the body. It could affect your heart because there are complications that can affect your heart, your lungs, your bones. Everywhere there's bone in your body, it can affect it. It can affect your kidneys, your liver, your reproductive organs. It can affect your legs, their leg sores, and everything in between. So right from your head all the way to your toes, there is a complication of some sort that you are likely to get when you have sickle cell disease. And this is amidst the health, the pain crisis that comes and goes on a very frequent basis. But with all of these crises, it goes to damage more and more organs as you go along and as you grow with the illness. So that is how dire and severe sickle cell is. But we talk about it very lightly because that people don't really see, right? You don't see that a child could develop stroke, but they can, and they do. A lot of the times they do.
Wow.
Yes. So I like to speak in layman's terms because I think that's when people can actually relate and understand, the
Yeah.
extent to which it can impact a person, a child, right from infancy all the way to the adulthood. And with that said, what I like to let people know is that, first of all, if we don't treat it as something that is a part of us, right? It's every single family, I can assure you, has a person within the family that has sickle cell disease. We may not know it yet, but it really is the
Yeah.
case. As more and more research are coming out, that is really the case for us, who are of African descent. So when you think about it that way, then we need to bring it to the doorstep of our community so that we can better understand what this illness is and how we can support each other with it, but also educate ourselves around the symptoms. And with that, we were able to form a stronger community around it. For me, one of the, like Enam said, there's definitely a gap within our system when it comes to having that strong voice. And so it's a matter of working and collaborating with everybody that's already in the space so that we can together have that strong voice. But for the foundation I established, one of because I've been in the space and I know some of the needs that are still quite haven't been met in the sickle cell space. My approach is a bit different because I've found that it's crucial to involve every single person that is a part of the community. So right from our market women, our opinion leaders, our chiefs, our imams, our
Okay.
police officers, our government workers, our MPs, everybody needs to be part of it. Our educational system needs to be front and center of the fight against sickle cell. So it has to be in our schools, because I am able to advocate for my child in school when they have a crisis, so that their homework can be packed for them and then they can do it later,
Yeah.
or that they can still have the opportunity to take their final exams even if they are in the hospital. So all of these are necessary and possible. And I think when some parents hear of these experiences and they know these things are possible, they're able to support their wards better who may have sickle cell disease. So, and even, our media engagement, we need to increase that. We really need to make it an everyday conversation for all of us to understand the severity of it, but also to know how to better support each other. And one area that I find interestingly that, needs a lot more education, even though, and I say that because in that area, you would naturally expect people to know much about it, but unfortunately, that's not the case. It's our healthcare community, right? Especially for for those who have to deal with the sickle cell treatments and whatnot, they are well versed in it. They know everything about it. But also within that same community, for those who don't necessarily have to interact with people with sickle cell disease, they oftentimes don't have a lot of information about it. So you might go to the hospital ER, and if that ER, the emergency is not well vexed, the staff there, the nurses there are not well vexed, or even the doctor isn't quite exposed to treating people with sickle cell
Wow.
disease. Yes, you might have to educate the person on what the disease means for you, what your symptoms and crisis look like, or they would have to call in an expert who knows. And with that, I also realized that in some regards and in some experiences, there was a lack of compassion for care, because if the nurse doesn't really understand how much pain you, the individual sickle cell disease, are experiencing, they would not treat you with compassion. And for a few of them, I've had to really educate them on what it means to go through pain crisis. And once they got a better understanding of what that meant physically, it was a different approach for them altogether, to understand that if a person is walking in here with pain crisis, this is not the time for you to dilly dally and doubt and give them all of this unnecessary stress
Advice.
about drug seeking and everything, because they are in the pain. If I can describe it according to the way a child described it to me initially, when my daughter was we were all learning about sickle cell, was that it felt like you had a car tire running over your leg
Wow.
for a child. That was how severe the pain was. So when a child describes to you pain in their arms or legs or any part of their body, and they, even though they can't say much of it, but if you think about that, just you have that visual alone in your head, that gives you a different perspective of what kind of pain that child might be going through. And this is just the pain crisis aspect of it.
So that's actually what I'm coming to now. My first question is, what are the various mediums through which you do the awareness and the education, and then tell us what happens with someone who has sickle cell disease. So, Vicky, you can start. How has it been like with your child? And then Enam, you also share your personal experience. But first of all, let's know how you're doing the awareness creation, which mediums you're using.
Definitely. So for me, it's everywhere, anywhere, and
Mm,
wherever the opportunity presents itself. This later this week, we're in one of the JHS schools where we're doing a sensitization exercise for the school children, and we've invited the parents to also be part of it. So we're in the schools, we're on media, we are in the churches, we're in the police
mm,
departments, we're in parliament if we need to be, we're in the hospitals, we're using our sickle cell association
mm,
organizations, because because serving as the president of the Sickle Cell Association for Greater Accra Regional Hospital Ridge, that gives me a place on the national executive
mm,
committee, so I'm able to use my voice on that national level. But I find that that is not enough. Right, we
mm,
have to be front and center and everywhere we can.
mm,
So for me, it's about reaching out to the president of the physicians a college association, the nurses, the midwives, everybody needs to be part of this conversation.
mm,
Everybody, and including our existing providers in the space. I
mm,
mean, like Enam said, we've interacted quite a bit on different platforms
mm,
with regards to sickle cell disease, but we really need to lend our voice in all the spaces and not limit ourselves to just the places that matter, because people in the markets need to know.
mm,
The
mm,
queen mothers need to know. I
mm,
was recently trying to reach the what do you call it, Mampohima, because she has a slew of queen mothers that under her umbrella. And if I'm
mm.
once that comes through and I'm able to reach her and her queen mothers, I know that is going to travel far and wide,
Yeah.
right? So we're looking at all of these opportunities where we can engage
Mm,
people, spread the word, but bring the information on sickle cell to our doorstep,
mm.
because it
Be-
affects every single one of us.
okay. Before you go on, when you mentioned Queen Mothers, this came to mind. In your education, do you consider language? Is everything in English, or do you have some in the local languages? Given the appropriate terms or the right terms for people to get a real understanding, especially for those who are either semi-literate or completely illiterate.
Right. That is definitely an area of need that we've.
Hello, hello, and can you hear me?
Yes, I can.
Hello.
Yes, I can hear you. Abby,
Okay. Did Vicky go off?
I think so.
Oh. Okay, then maybe you can help us if you have any
Yeah.
idea.
Yes, so we definitely consider language as a key part of the work that we do. So I know
Okay.
that for Sickle Life, for the past 2, 3 years, we've done translations into various languages. So we have these
Mm.
audio and audiovisual um, stuff that we did, where
Materials.
it was sickle cell in Ewe, Ga, Chi, some northern
Mm.
languages, we actually had our own volunteers. That's people with sickle cell themselves or their
Mm.
caregivers on our support groups who translated it themselves, and then we
Okay.
had them on our various social media platforms. Of course, I can admit that not everyone is on Instagram or on Facebook
Mm.
or Twitter. So there's more need for us to go into the communities. And
Mm.
as Awo said at the beginning, a lot of our work is centered in Accra and maybe Cape Coast,
Mm.
Kumasi, because a lot of us are here. We have volunteers in those other regions, but generally, when we want to do an awareness creation project, we need to have our core team of lab scientists, doctors, just a
Mm.
few of the core people from Accra going there to give directions on how to run the program, but then generally would get the volunteers from those regions to come. And financing has been a problem, but yes, we have translated into the various languages, but I guess it will be those who are on social media who can access them. And I co-sign with everything that Awo said. We use essentially the same platforms in reaching out to people, but it seems like we need to do a lot more, and we also need to make whatever we are saying more real to people, because what ends up happening is that people who we might have seen for several years on our platforms end up coming to us much later when they are getting married or have a kid. So then it seems like the message was just being received passively. So we have to find a strategy that will make the message more real to people, so that it's not get tested when you are getting married or get tested when you're about to have kids, but it's a get tested now, know your genotype and make an informed decision. Get tested and know about sickle cell and just be aware about the condition. But yes, I co-sign with everything that I was said. Regarding what happens with sickle cell disease, I mentioned that there's a problem with hemoglobin, so it's a hemoglobinopathy. And so when this happens, it changes the shape or the conformation of the hemoglobin molecule, and this results in a red blood cell that is not the usual shape of red cells. Red cells are usually small, they are very flexible, they are what we call biconcave disc shape. They're able to go through the very tiny vessels in our body, everywhere in the body, to supply blood and take out, to supply oxygen and take out carbon dioxide and other waste products. And so, just as I was said, because red cells go everywhere, when you have sickle cell disease, the complications can happen everywhere because the red cells are going everywhere. So once you have sickle cell disease, your red cells change from this biconcave disc to a sickle shape, and that's why it's called sickle cell disease. So those red cells are hard, they are sticky, they are firm, they are not able to permeate through the various blood vessels easily. And so they cause obstruction in the various vessels. And once vessels are blocked, one, oxygen is not going where it needs to go, and two, waste products are not coming back from where they need to come from. And that is just one of the main ways by which the sickle cell disease or the genetic change causes disease in a person who has sickle cell disease. But then there are so many other mechanisms of action by which sickle cell disease causes its havoc, right? So there's something called sterile inflammation, such that a person with sickle cell disease has all these inflammatory cytokines. Usually, when you have an infection, your body releases chemicals to help you to fight the infection. But in somebody with sickle cell disease, even without an infection, their body is always in a state of releasing these inflammatory cytokines. And all of these inflammatory cytokines work together with these sickle cells to cause obstruction of the vessels. Apart from that, in somebody with sickle cell, their spleen may not necessarily be working well. And if your spleen is not working well, your ability to detect, or yes, let's call it detect, or it's called opsonize bacteria, is not as good as everyone else. So because of that, you are at higher risk of getting infection. The spleen is not able to trap bad or microbacteria. It's not able to trap organisms that may be in the blood. So that may be a way by which they may get infections. They are not able to trap encapsulated organisms. So when you look at the way sickle cell disease causes disease in people with the condition, is not just by virtue of the sickle cell disease, the sickle cells blocking the vessel. There are so many different mechanisms of action. And so it's important that we look at this condition holistically. At this point, we need to move away from the symptomatic management of sickle cell disease, where it's like, oh, the person is in pain, let's give them a painkiller, let's give them fluids to let the cells move through the vessels. Again, at the very beginning, I talked about the fact that the normal is A, and then the abnormal is S with another abnormal one. But indeed, there's another one called C. So when we talk about the S ones, where they crystallize or they form S, they join each other, the C one has a very different mechanism of action. And so if we don't recognize that there are various types of sickle cell disease and the way they cause sickness is different, we would downplay the disease itself and reduce it to the people have pain all the time, so let's give them painkillers, or the people have pain, so let's give them fluids. And so based on this, the new, it's not even so new. Since the 90s, we've moved on to disease modifying agents in the management of sickle cell disease. And so now you realize that, for example, in the United States, since the 90s, started giving medications such as hydroxyurea. And what hydroxyurea does is that it reduces the amount of the S, which I said was the abnormal, the hemoglobin S, right? It reduces the amount of that, and then it increases the amount of another hemoglobin that's in the blood. That's the hemoglobin S. And so once you are addressing the real reason why a person with sickle cell disease is forming sickle cells, then you are getting to the bottom of the condition, such that they are not going to have the blood vessels to end up having the pain. So that's just one medication. There are other disease modifying agents that are currently available. There's one called crizanlizumab. There are other ones called L-glutamine, voxelotor. Of course, we don't have access to everything here. So whilst in the US and in the UK, there are a lot of options. So if somebody is on hydroxyurea and maybe they are not having the best of response, they can be switched to another, or another one can be added. Here, it's a little challenging to even get hydroxyurea because fortunately it's been added on NHIS, but then it's not always easily available. But then the key point is that just as if you know somebody with hypertension, you will not wait for them to get a stroke to manage the stroke, or you will not wait for them to get MI, or what we call heart attack, to manage the heart attack. We also have to think about sickle cell, that if somebody has sickle cell, we are not going to wait for them to get a bone pain, or to get a complication like avascular necrosis, or to get a stroke before we manage the stroke. We would give them medication, as in hypertension, as we give medication to control the hypertension. We also give medication in sickle cell disease to address the underlying problem in the sickle cell disease. So yes, there are these disease modifying agents. Another thing for management of sickle cell disease is that you can give blood and blood products. Before hydroxyurea became mainstay of therapy, for children who had strokes, for example, we used to give blood, right, as an exchange transfusion, where you would draw out the person's blood, which contains sickle cells, and give them an exchange with somebody's blood who doesn't have sickle cell. The whole idea is that you are diluting out the sickle cells, because again, these cells are hard, they are sticky, they block vessels. When the vessels are blocked, oxygen cannot get where it has to go, waste products cannot be brought out. So once you are removing that blood and giving new blood that doesn't have the sickle cells, you are minimizing the chance of getting the complications or the crises that we know about. There's something also called apheresis, where it's a similar process of giving the blood, but in this case, it's a machine that removes the blood, and it's in a cycle, or a cycle. You remove the sickle cell blood, and then you are replacing with non-sickle cell blood in a circuit. In addition to that, you can also give antibiotics as prophylaxis. As I said, the
Okay.
mechanism by which people with sickle cell fight infections, and this is even before you are sick or have crisis, is impaired. On a normal day, your spleen is not working the way it should work. Either it's infected, that's the sickle cells have blocked the sinuses, the vessels in it, such that it's not working the way it should. So we give the children penicillin V. And I'm sure we might have seen the statistics that said that about 90% of children with sickle cell disease in sub-Saharan Africa die before the age of 5. That's a very troubling statistic. So for me, when I hear people, and we might have heard, people will say, oh, sickle cell there is people with money who have sickle cell, or it's rich people who have sickle cell. If you think about this statistic, that 90% of people with sickle cell under 5 will die before the age of 5, then you are probably just seeing those who could afford care. The people who were dying and being diagnosed of malaria and before they could be tested for sickle cell are not being accounted for. Hopefully this statistic has improved, and we just have to do the research to see what the figures are now, because now there's more access to penicillin V and the likes. And also, of course, when you have a child with sickle cell, you need to ensure that they get all their vaccinations. And that thing is that, and here in our setting, we, for a very long time, this is what we used to give a lot. That's the supplements, a lot of vitamin C, folic acid, zincovate, and the likes. And in my work with the advocacy group, I find that a lot of the adult patients still swear by the supplements and are resistant to the disease modifying agents. There's nothing wrong with supplements in sickle cell disease, okay, except for iron containing supplements if you are not proven to be iron deficient. The supplements are important because by virtue of how sickle cell disease works, you might end up breaking down your cells faster than normal, your red blood cells faster than normal. And so if you are breaking your red blood cells faster than normal, it only stands to reason that you supplement yourself with the raw materials to produce new red blood cells, because your body is breaking down red cells faster than normal. And that's the only reason why the supplements are beneficial. But then it doesn't address the underlying problem with sickle cell disease, because you will still get the supplements and produce red cells and they will still be broken down. You are just feeding the factory to continue the breakdown process. So the supplements are just kind of adjuncts to the management of sickle cell disease. But the real management of sickle cell disease, and this is something that we should all take note of, is disease modifying agents. And of course, the analgesics and then the hydration is something that we are all, well, most health workers are comfortable with, because that's what most people will come with, because we'll complain about pain and the likes. In terms of curative therapies, there's bone marrow transplant. And
Okay.
for this one, it's the case where if you have sickle cell disease, they would use the stem cells of a relative or a donor who does not have sickle cell disease, so someone who is AA or AS or something else, and then they would transplant that bone marrow into you after you've undergone conditioning. That's a bit of chemo to wipe out your bone marrow, and then after that, the bone marrow that grows in you is no longer bone marrow that has sickle cell. And
Yeah.
then recently we heard about gene therapy. So gene therapy is similar to bone marrow transplant, except that now we are not giving you somebody else's bone marrow. So then you are not going to have the risk of graft versus host, but we are putting certain modified viruses into you that would, after you receive the chemotherapy or the conditioning, such as now they would change the mutation that we mentioned at the very beginning as the underlying cause of sickle cell disease. And then from there, now whatever grows doesn't have the sickle cell disease again. So now your bone marrow comes out like going on without sickle cell disease. So that's an overview of management in sickle cell disease. And I was very deliberate about not talking about the types of crises, even though that's how we all learned about sickle cell disease. I wanted to rather talk about them in terms of disease modifying agents, the supplements and the likes. But then I can still talk about it in terms of crises, because when a patient comes to you in the hospital, of course, in that acute condition, it's a type of crisis that you will be managing. But then for a regular patient living their day-to-day life, what we need to maintain good health and to keep us alive longer is the disease modifying agents and the other adjuncts that help us to stay healthy. So that's how come I went by this route.
Okay. So you spoke about the bone marrow transplant.
Yeah.
What's the success rate?
So bone marrow transplant in itself has, the success rate is dependent on a number of factors. So first of all, the age of the recipient, that's the patient, then the also the age of the donor, are they HLA compatible, are they like partially compatible and things like that. So there are a lot of factors that come into play, but then the complications are what make it a little troublesome in terms of the fact that you can get graft versus host, where the bone marrow you receive fights your own marrow, because it's like it's a stranger and you have been given medicine to weaken your immune system to receive that bone marrow. So that's where the challenge is. Or in some cases, people actually reject. So you can have graft rejection, where you, the recipient, your bone marrow, even though it has been weakened, doesn't accept the bone marrow you were given. So the success rates, I can't give a specific figure, but then it's dependent on whether it's a sibling match or a stranger but HLA match. Yes, it's quite expensive. It's not accessible to us here in Ghana currently, but if you have the funds, you can go to maybe India, South Africa, UK, and the likes. I think gene therapy was, I think $6 million or something, if I remember correctly. If I remember correctly, it was quite costly. Bone marrow transplant is about, was it 150,000 USD? Yeah.
Wow. Okay, Vicky, are you there?
Yes, I am.
Okay. Can you tell us a bit more in terms of, I think Enam has said more about how sickle cell affects the body internally, so to speak. Can you touch on its manifestation based on your experience with your child? What are some of the things that outwardly are seen, and how have you managed it?
I think for me, I would consider myself blessed because we haven't really experienced a lot of physical deformities, if I may put it that way, or features that are commonly associated with sickle cell disease. So I mean, with the exception of the usual yellowing of the eyes, jaundice, which is something that every now and then manifests itself. There's hardly ever any physical symptoms or signs that you see or that we have experienced that I can speak to. So thankfully, I think that we've tried our best to kind of stay on top of situations so we don't have to get to that point. But there are times when you're not also you can't do it all because again, sickle cell, the illness and its effect kind of creeps up on you. And so more recently we had to deal with stage 1 of avascular necrosis, which again was something that again, we never encountered it, never saw it as a problem. And when it came, and it just started off with my child saying that they were experiencing pain in the hip, right, the pelvic region. And so from seeing an orthopedic doctor to getting referred to Focus Hospital to see additional specialists and all, and a number of MRI testing, X-rays and whatnot. The diagnosis was that they were developing, avascular necrosis, which is sort of the dying of the head of the hip bone. And if that progresses, they could need a replacement of the hip. And that also affects the person's mobility and how they walk, and could actually change your form altogether, because it could change entirely how you you move and walk.
Yeah.
And that area is the center of everything, right? So then we had to look at what options there are for treatment, for therapy. So a combination of physiotherapy, which is more physical, hands-on, techniques that they have to do to manage the situation so it doesn't progress, or that manage the pain associated with this, but also swimming, and then also ensuring that we're monitoring it closely so that it doesn't progress. So there's some of these things that can manifest itself, even if you're doing everything right you need to do to manage the illness. And I'm really glad that Enam had, talked about the various aspects of managing the illness, which is sort of like one area that we are looking to spread the word and make sure that it gets to all parts of the country. We have all of this centered in one place, and it's based off of the treatment guidelines that was established by what do you call it, the standard of care for sickle cell in sub-Saharan Africa. Was a group of doctors, professionals that came up with these treatment guidelines. And we found that on just at the basic level, if these treatment guidelines can be implemented everywhere within the country, we will get somewhere very far with sickle cell disease, because it encompasses everything that Enam talked about, from right from newborn screening, which is when the child is born, to be tested. And then at that point, if they're diagnosed with sickle cell disease, treatment can start right away with the antibiotics, the penicillin, making sure that they are, their immunizations are squared off. But also, more importantly, pneumonia vaccine is a key one that the children need to have, because we found a lot of children, and it's extensive research, and a lot of children dying from pneumonia early ages, because that was not something that was we had paid attention to. So right from there to the blood transfusions, the hydroxyurea medication, which has been phenomenal, and even like the testing for detecting stroke, transcranial Doppler. Those are key aspects of the treatment guidelines that we have to ensure is in every single nook and cranny of this country. Wherever people with sickle cell are, that they need to be treated or ought to be treated, people need to know, and there has to be a uniform way of ensuring that these treatment guidelines are disseminated, but also implemented in our various hospitals and clinics. The problem we have right now as a country is that not everyone knows about these treatment guidelines. The information isn't out there, and we don't have enough skilled providers in the remote areas to manage this on their own. They need government support, they need the communal support. And so getting to them, making sure that the government knows they exist, they're there, that we can mobilize support around them and make sure it's done. It's sort of our key mandates, really, as a foundation, and sort of one of the biggest areas that we want to focus on. It's so key that everybody knows it, and to also bring some of the healthcare providers along, because there are currently healthcare providers in our sickle cell space who know very well what these treatment guidelines are, but they do not implement it, and they are not educating their patients about it, and that is a problem too.
Okay. Talking about education in the health sector, I know that currently there's some work being done around genetics and then genetic counseling. Is it happening in the awareness creation in the health centers, and to what extent? Is it what's the word to use, substantial enough? Are they giving enough information about genetics, how to check, what to do, what not to do? I don't know if Vicky, sorry, I will. You
Well, I
like to
think
start on that?
I on Enam because she is, directly in the healthcare centers. I mean, I
Okay.
know that there's been recent talk about the genome project and
Mm-hmm.
uh, gene therapy kind of trickling
Mm-hmm.
down from from the international stage into our countries, and it comes at a very high cost.
Mm.
So with that said, I know that we are trying to manage sort of, the treatment guidelines in itself.
Mm.
And if that affordability is the problem, so I'll let Enam answer the question on whether, where anything's being done about it in the treatment settings. She just works
Mm.
in the treatment setting.
Yeah. So for genetic counseling, I guess with respect to I don't know, premarital counseling and the like, what's happening in our centers is that most of the genetic counseling is based on the healthcare workers' knowledge about the condition.
Mm.
So what ends up happening, at least in my experiences, for colleagues who think that they want more information from a hematologist, they'll generally call a hematologist that they know personally or they know that is in the space. So I often get calls from colleagues about people who may have issues about AS, my partner is AS, or maybe I did a test and the genotypes are looking weird. Like maybe previously it was AA, now it's looking AS or it's AC. So generally, sometimes we get those calls that what should they do? But
Mm.
then we've also had instances where people would come to us and tell us that they've gone to a health worker and that they've been told that your genotype doesn't matter, have faith, it doesn't matter. So what based on my experience, it seems like the counseling is based on the experience and knowledge and sometimes personal opinions of the healthcare provider with respect to their condition. I know that currently, I think it's the West Genetic Medicine Center at University of Ghana. They run a genetic counseling course, and people are being certified to be genetic counselors. But then I don't know about their placements in the healthcare facilities. But I think that once they graduate and they start being placed into the health facilities, it will help.
Mm.
I don't know that your question was about this genetic counseling or about the the gene therapy.
Mainly about the counseling.
Okay, so then
Mm.
yes, so in my experience, people are getting different counseling based on who they see, and it's the same thing at like in churches and in other places. It depends on who you talk to and what
Mm.
they personally feel about it. But then some people would refer them to us to talk to them.
Mm. So it's not included in reproductive health care, I should say.
So there is sickle cell testing for the pregnant women, but
Okay.
once you are pregnant and you come, at that point, I
Mm.
don't think people would do. Nobody's going to terminate at that point. Well,
Yeah.
most people will not terminate at that point. So
Mm-hmm.
you get to know at that point. Yeah.
Right.
Yeah.
And just to add to Enam's point, I think I've actually been somewhat pleased that some of the churches have actually taken on this role where they actually require maybe a couple who have plans of getting married to come
Mm-hmm.
with their test results, right? So they
Mm.
want you to get tested so that and some have even gone to the point of refusing to marry you if they know that the couple have a higher
Mm.
chance of producing offspring with sickle cell disease. And so at that point you are left to your fate, or you might want to reconsider whether getting married is the right thing to, or having children might be the right thing to do. So I think that is good, good in a way that it protects the couple from knowing and understanding what they're getting themselves into, so that if they are to decide to go along with their marriage or whatnot, and they start bearing offsprings, they understand that this is what we are to expect, and
Yeah.
maybe they educate themselves to know how to manage their children better in that situation, and not fall into this trap where the husband thinks that it's the wife's fault for the child being you know being born with sickle cell disease, and vice versa. And then they get into these issues where one family thinks that it's just a quote unquote, and it's sadly they'll say you've given birth to quote unquote an evil child, because the child is always sick. You're always in and out of the hospital. We're always spending money on the child. You're always crying. The nuns, there's all of these psychological, issues that comes with, having to manage a situation, especially when you yourself don't understand the illness well enough.
Yeah.
It's tough on parents, and sometimes the burden might be left on one parent and not the other, because it's lack of understanding. So I'm really glad that the churches actually have gone the next step. A lot of it, and I think that most of them are coming along too, where they're saying, "We need you to go get tested, bring the test results to us, and let's see whether it's even possible for you guys to get married." And that, I think, it's a step in the right direction.
I think
Let me
like
also
Enna
reiterate that
mentioned about the pregnancy with
yes.
the
So
premarital counseling. I feel
yes,
like this test should even come earlier, not immediately
exactly.
before marriage, but maybe once you meet somebody and the two of you agree that okay, we're going to get serious with each other. It's advisable to do it at that stage, because just before the wedding, I mean, at that point, you're so into each other. Taking that decision to go your separate ways can be really difficult. So I think the church has to look into that as well and advise people to, as soon as possible, do the checks and take decisions based on that. If you still decide to go ahead, like you said, you know what to expect, so you don't blame anybody. Yeah. Sorry, Enam, you
And
wanted to say something.
yes, that there are several levels of prevention, and we try to explain this to everyone that get knowing about your genotype early and then making the informed decision is up to you. So as I said earlier on, knowing way in advance and deciding that based on the genotype, you will not date somebody because you are AS or whatever permutation, that's up to you. But then there are people who would also say that we have the same genotype and our child could have sickle cell disease. But as I was said, we would proceed to have that child because now we've heard about bone marrow transplant, despite the cost and the risk of rejection or graft versus host, and or we would look for the millions of dollars and do gene therapy. And then there are some people who think that should they have a child with should they get pregnant, they can go and do IV, they can do selective abortions, and that's an option that is available and even done in Ghana. Some people think that they can do IVF with genetic selection. So the thing is that there are options, but then you are better off knowing in advance and preparing for it rather than being surprised. I know that sometimes it's controversial when we are advocating because they'll say, for example, I will say her daughter has been fine the whole time. She only gets small jaundice, and it's now that she's beginning to have stage 1A vascular necrosis. So essentially, her life has been good. So then why are we saying that people shouldn't have their children with sickle cell disease? So it becomes a question of why are you trying to prevent the condition if it's not that bad? But of course, they don't know the struggles that Awo and her child has gone through. So we try to put all the information out there and then lay out all the options. And then it's up to you. If you think that despite everything that Awo and her child have gone through, or despite everything, you still want to go through it. It's difficult, but then we respect your autonomy and leave you to make that informed decision. At least that's my stance on this.
Okay. We still have a few minutes to go. So, in closing, I'd want each of you to share your personal experience and how you would advise people, based on what you've been through. I'll start with our.
Well, it's sickle cell disease is a part of us, as we all have come to know, and it's also an individualized journey in the sense that everybody's condition presents differently at every stage and any stage. Just like how my daughter has been blessed enough to
Hello?
not have to um, encounter a lot of
Hello?
challenges. There have also been some serious challenges because
It
of
looks
minor
like she's gone
infections
off
that.
again. Okay, Enam,
Oh,
you can go
Oh
ahead.
no, she's here.
oh, can you hear me?
Hello?
Can you hear me?
Enam,
Hello?
can you hear
Yes, I
me?
can hear.
Hello?
Is Vicky there?
Hi, Abigail.
Okay, please go on.
Can you hear me? Okay, all
Yes.
right. So I was just saying that it's as much as some situations are more severe than others. It's also an individualized journey and how you manage. You learn to understand the illness, identify your triggers that could lead to crisis, and then you develop a plan, an individualized plan around managing those triggers, so you have
Okay.
less crisis and you don't have to endure a lot of the complications that may come about. But then there's some complications too that you have no control over. They may come about, and when that happens, you learn about them and then you find a way to manage those complications. So I think in a
Okay.
nutshell, that's what my experience has been. For me, because this is so dear to my heart, and because I've established a foundation that is looking at these key areas that we all need to know about when it comes to sickle cell disease, I find that if we're able to do sort of like the basic implementation of treatment guidelines, we are bound to go a very long way with people who are currently living with sickle cell disease or who are going to be born with sickle cell disease, and that would take us a step closer to us being more aware, and be more supportive, but also having a stronger voice when it comes to advocating for our needs. So that is what I would say with my experience and where I see this going.
Thank you. Enam.
You're welcome.
Yes, thank you very much. I agree completely with everything Awo has said. Um, the issue about the treatment guidelines, um, the level of care that persons living with sickle cell disease receive at various health centers is not the same. And so, unfortunately, we have a situation where people would rather stay home than go to the hospital if their primary facility is not open, and that can end up being dangerous sometimes. And so, as I was said, once we can get these guidelines across the country and implemented, it will make a world of difference in the lives of persons living with sickle cell disease. And that thing too is that the thought or the school of thought that a particular genotype is more severe than another. Yes, rule of averages. So on average, people who are SS or S beta thal generally have a more severe phenotype. They have more severe disease. But then people who have other genotypes, SC, SD, SG, and the rest, tend to have other form manifestations. So it may not necessarily be that, okay, because you don't have SS, you will not you will be fine. Because there's people who are SS who have never been sick. right? And so we need to disabuse our minds of that thought that somebody is SC, so they'll be fine. Because I keep saying, when people say that a sickle cell patient has surprised them on the ward, that's one thing that I really, it breaks my heart, because not there's everything that we call a surprise about persons living with sickle cell disease is something that is known, it's something that is studied, it's something that is written. It's not surprising, it's known that it would happen. So if we sit down and allow ourselves to be surprised, then we are really doing persons living with sickle cell disease a huge disservice. So let's please disabuse our minds from this perception that because you're a particular genotype, you are expected to come in a particular way. Because when we do that, then it is the people that we think will be fine that will end up surprising us. And again, people who have these genotypes that are thought to be mild, sometimes they come. We know that, for example, SC has an increased risk of sickle cell retinopathy. So this is something that we should keep at the back of our mind. Some literature says that because SC has high HB, sometimes they have increased risk of vaso-occlusive or pain episodes. They have increased risk of avascular necrosis because of hyperviscosity. This is literature that is known. So when you begin to separate them according to this person's genotype is this, so they will not be this, in the end, we do more harm than good. Yes, more people with SS will generally have lower HB and they may have end organ damage. But then the people that come in and sometimes they've never had a crisis in their lives, as people like to say, they end up surprising people. So please, let's be cautious. And again, I will say this. Sometimes a person with sickle cell disease can do everything by the book. You can hydrate all you want. You can avoid all the stress, to take all the medications, do everything that has been said, but then crises end up happening. And when that happens, you shouldn't say the person is not following instructions or the person is not being a good patient. It's the pathophysiology of sickle cell is diverse, and we've talked about some of it. So sometimes it's just cells doing what they have to do. It would be managed, and then the person will pass through that. So I want to entreat all of us, like it's a multifactorial condition and it's a multi-systemic disease. When somebody with sickle cell disease comes, please, especially to the emergency, most parents know how to manage the acute pain episodes, and even the adult patients, they might have taken the mild analgesic, the paracetamol, maybe diclofenac and ibuprofen, and they most likely know what works for their pain. So when you go back and you start them from what they've taken 6-8 hours already, we are just extending the period in which they are in pain. And we know that when the VOC stays for a long time, the risk of dreaded complications increases. So it's important that we listen to our patients and follow the guidelines about the first analgesic going in about 30 minutes to 1 hour of a patient with sickle cell disease coming into the emergency room with a pain episode. It's also important that we differentiate the types of crises. I tried not to center the types of crises too much, because it seems like we've done that a little too much in our management of sickle cell disease. But please, not everybody who comes to the emergency room has a VOC, has an acute pain episode, and needs hydration and fluids. Sometimes somebody will come in with sickle cell disease and it's not a vaso-occlusive crisis, it's not a bone pain crisis. The person is having splenic sequestration or sequestration into the liver, and maybe the parents of a child have palpated and they can tell that the child's liver or spleen is enlarged. Management is different. They don't need fluids. Maybe they are having an aplastic crisis. Maybe they are having a hyperhemolytic crisis. Different things happen in a person with sickle. Maybe they are having a septic arthritis. Maybe they're having malaria. A person with sickle cell disease can have different things. Maybe it's an acute chest syndrome. But then the management has to, because it sometimes it's heartbreaking that you would find a person with sickle cell with a totally different condition, but then the person is being managed for a VOC and being hydrated and things like that. So my appeal is that we should see sickle cell disease as the multi-systemic disorder that it is. That it's, as I was said, it affects us from head to toe. The crises are different. The complications, stroke to leg ulcers and everything in between. So when the patients come, a bit of empathy. The person has been dealing with a lot on a daily and have probably made a hard decision to show up at the ER because they knew that they were going to go through a lot, but then they couldn't bear it with their over-the-counter medications, and so had to come to the emergency room. So please be empathetic, please be understanding, and just assist us for the short period that we will be in the emergency, because honestly, nobody wants to be in the emergency room. We also have things to do, and every time we are on admission, it actually disrupts our life, because then you come back and you're like, where did these days go? Like, you have things to do. So that's really all I have to say. Thank you very much.
Thank you. So from what you said, is it right to deduce that, let's say with malaria, if a sickle cell or someone with sickle cell disease comes in, you treat them differently for malaria than you would someone who doesn't?
So it depends. Sometimes the malaria can precipitate hemolysis. So it may end up causing hyperhemolytic crisis. The malaria can end up precipitating a vaso-occlusive crisis. So you have to, it's like that high index of suspicion just because it's a sickle cell disease patient. But if somebody with sickle cell comes and maybe they have malaria and then they just come because they are in pain, and you are just treating them pain, but you don't investigate for the malaria, you keep managing for pain and they will not improve because there's an untreated malaria. If they come and then they are hemolyzing and you think, oh, it's a normal sickle cell jaundice that they usually have, but then they tell you that this jaundice is more yellow than the normal one, and my urine is not this black usually, this one is more black than normal, so there's something extra about this one. So please, like, there's something extra, so then you have to go further. So that means maybe it's an infection that is causing this hyperhemolysis more than the normal hemolysis of sickle cell. So a person with sickle cell can have any of these things precipitated by other things. They can come in with things that they will look like a normal pneumonia that everybody has, but then you turn your back and come back, it's acute chest syndrome. All the chest signs have changed, and now they are disappearing. So it's, things change rapidly, and so you need to have a high index of suspicion when you have a person with sickle cell as a patient. Other than that, we keep on saying they are surprising us, they are surprising us. But for me, it's a little heartbreaking that people with sickle cell disease keep dying, and it's like, it's normal for us that we expect a young person with sickle cell disease to die. So it doesn't affect us. Like, we should ask ourselves questions, because the life expectancy has improved. A lot of children with sickle cell now, they started hydroxyurea as babies, so like, we expect them to live long. So once somebody with sickle cell dies, we shouldn't take it as a normal thing. We need to ask probing questions.
Okay, finally, what seems to run through, or one of the main things that I've picked up from our conversation, is an obvious gap in research. In your work, Awo, you and Enam, what was lacking in the research, and what can be done to improve upon it? I'll start with Awo.
Well, I know it's a number of research scientists within our community that are doing great work in the sickle cell space. For one, Professor Sampani Donko at the head of microbiology at University of Ghana Medical Center has done extensive work in research with regards to sickle cell disease, particularly with pneumonia and how that affects people with sickle cell disease. And there are other medical professionals who continue to do extensive work in sickle cell disease, both internally in Ghana here, but also on the international stage. So I know that there's a lot of ongoing work being done. And one thing that we've also come to realize is that the world in itself is paying attention more to sickle cell disease right now. We have the likes of Professor Isaac Odami, who is, is the head of the World Coalition for Sickle Cell Disease, and he's based in Toronto. But his body of work is so extensive when it comes to sickle cell disease that it gives us hope. And we're excited about all of these people doing great work in the sickle cell space. Dr. Vivian Pencil has been extraordinary when it comes to sickle cell disease. So there's so many, of our professional health professionals, medical academia, right, who are doing various things in the sickle cell space with regards to research or promoting research, helping to implement some of these research findings. And that is, for us, is exciting because we know that there's more to come with sickle cell, but it's also it's more related to us, right? Us here in sub-Saharan Africa, our and when you talk about us, you have to take everything into consideration. The need, our weather, our climate, right?
Yeah.
Our living environment, all of that comes into play. So it's more individualized and focused, and that is the exciting part about it that I am looking forward to when it comes to research development in sickle cell space.
Okay. Thank you. Finally, and
Yes. At the Ghana Institute of Clinical Genetics, the Korle-Bu Sickle Cell Center, they are doing a lot of groundbreaking sickle cell disease research, and I think that they are even at par with most of the ongoing multi-center research on the new disease modifying agents in sickle cell. So I think that that's really good. The only thing is that the challenge will be that for most of the new molecules, after the research is done, the issue will become, can the average patient afford it? So I know that for some of the new molecules, they do like programs where for the people who were on the trial, you can still get it on some other program after the research. But then the important thing is that, again, it's an incentive. Like, we should get more of people to be interested in research, that are patients or caregivers, such that then you get access to these very expensive medications that you otherwise wouldn't get access to. So that's a plus for us on the research side. But then I think that so those are the clinical trials. I think that the area where maybe we could do more on, and I'm sure maybe Awo and I or the other health advocacy groups can work on, is the social aspects of sickle cell disease. So the things that we as advocacy groups do. So we could look more about into things that are affecting caregivers, patients. So there's just the social things, and then see how we can work on improving them. So maybe that's a gap that we can look at filling.
thank you so much. This has been really educative. Thanks a lot for sharing your own experiences and then the knowledge that you've gathered over the years. I want to believe that all that we've heard today has improved our awareness, and it's also going to improve the way we treat people with sickle cell disease, how we think about them, and we'll be intentional about being supportive. Like Enam, you rightly said, sometimes when it's not you or it's not close to you, you tend to take a lot for granted. I hope that we'll not wait till it comes near us before we take action. Thank you once again. So this has been the IMANI REVEALS show. This is where we speak, we are real so that we can live. And today we talked about sickle cell disease. Before we pray, we'll say before we go, we'll say a word of prayer. Awo, can you please pray with us? Is Awo there? Oh, she's gone off. Okay, Enam, please pray with us.
Dear Lord, we thank you for today. We thank you for this very informative program that you've allowed us to have. We pray, Lord, that everything that we've said today will touch the hearts of the right people and that it will make impact in the lives of every single person who has heard us. We pray, Lord, that you enable each and every one of us to continue to be change makers everywhere that we go. We thank you, Lord, for answered prayer. Amen.
Amen. Thank you so much once again. And God willing, we'll meet again next week. Until then, speak, be real, and live not just any life, but the abundant life that Christ has given us. Have a good night. Bye.